Hello and welcome everyone. Today our topic of discussion is nasopharyngeal carcinoma. Nasopharyngeal carcinoma is a rare form of cancer arising from epithelial cell lining of nasopharynx. Let's dwell into the etiology, symptoms, diagnostic finding and treatment option. It is most common malignancy of nasopharynx. Etiology of nasopharyngeal carcinoma is multifactorial with genetic predisposition and environmental factors playing significant roles. Genetic predisposition, particularly involving genes like HLA and viral oncogenes LMP1, LMP2, and EBNF1, have been demonstrated to play an important role. Chinese ancestry remaining an independent risk factor. Other environmental factors include Epstein-Barr virus infection and cigarette smoking, heavy alcohol consumption, consumption of preserved foods containing nitrosamines are associated with increased risk. The World Health Organization has classified nasopharyngeal carcinoma into three subtypes based on histology. Type 1 is keratinizing squamous cell carcinoma associated with EBV infection. Type 2 is differentiated non-keratinizing carcinoma. Type 3 is undifferentiated carcinoma, the most common subtype of nasopharyngeal cancer. Let's see the symptoms of nasopharyngeal carcinoma. They include persistent nasal congestion, blood-tinged mucus, recurrent nosebleeds associated with nasal symptoms. In the ear symptoms, they are secondary to eustachian tube obstruction by tumor, which are conducting hearing loss, middle ear effusion, and oral fullness. Cranial nerve palsy can be found in 20% of cases. Neck lymph node enlargement are also seen. The lymph nodes of apex of posterior triangle and upper jugular are initially most commonly involved, together with retropharyngeal nodes. Supraclavicular nodes are the last to be involved and are sign of advanced disease. Distant metastasis can be seen in advanced disease. The most significant spread includes liver and lung. Now let's see the evaluation. The baseline investigation may include the complete blood count. Renal and liver function test can be obtained if there is a concern for metastasis or paraneoplastic syndrome. Epstein-Barr virus serum IgA level may carry a diagnostic and prognostic significance. EBV DNA is detected in 75% to 100% of nasopharyngeal carcinoma cases using PCR or FISH. The most common imaging modalities used in evaluations are CT scan, MRI, and PET scan. CT scan with IV contrast is a modality of choice for bone invasion and in assessing the cervical nodal involvement. MRI is useful for assessing intracranial extension, cranial nerve involvement, and defining the paranasal sinus involvement. A PET scan is useful for assessing remission and investigating the recurrence. And the next is endoscopic evaluation. It is readily accessible for biopsy via endoscopic or transnasal routes. The cytological findings include clusters of malignant epithelial cells with pleomorphic nuclei and prominent nucleoli. Now let's learn the histological findings. Gross pathology finding may be variable, includes friable ulcerated mass or smooth mucosal bulge or infiltrative mass. Nasopharyngeal carcinoma exhibit distinctive histological features with three main subtypes. Type 1 keratinizing. Histologically indistinguishable from keratinizing squamous cell carcinoma in other body sites. It can be graded as well, moderate, or poorly differentiated based on the degree of keratinization. Type 2 is non-keratinizing, characterized by cords or trabeculae of interconnected cells with well-defined borders and little to no keratinization. Type 3 non-keratinizing displays one of two predominant patterns, though this pattern do not appear to affect prognosis. First is Regaud's pattern, the cohesive pattern with distinctive margin arranged in syncytial pattern, and Schminke pattern, non-cohesive cells with diffuse cellular infiltrate resembling non-Hodgkin's lymphoma. Immunohistochemistry is crucial in characterizing nasopharyngeal carcinoma by detecting specific protein markers. Positive staining is observed for following markers in nasopharyngeal carcinoma: They are EBV latent membrane protein, high molecular weight keratin, pan-cytokeratin P63, P40. Negative staining is noted for following markers: CK20, CD45, S100, HMB45, melanate, desmin, myoglobin, myogenin, CK7. The treatment and management of nasopharyngeal carcinoma depend on the stage of disease and may involve the combination of radiation therapy, chemotherapy, and surgery. Non-surgical approaches are primarily mode of treatment for most nasopharyngeal cancer. Anatomical challenges posed by nasopharynx makes surgical access difficult. Radiation therapy is an essential treatment modality for nasopharyngeal carcinoma. In stage 1 nasopharyngeal carcinoma, radiation therapy is used as a single modality treatment and chemotherapy is added for more advanced stage disease. There is a significant improvement in survival of patients with stage 3 and locally advanced stage 4 nasopharyngeal carcinoma were treated with bimodality therapy comprising of radiation therapy with systemic chemotherapy. For patients with stage 2 disease, the role of chemotherapy depends on the status of lymph nodes. The platinum-based agents are recommended for all patients undergoing induction chemotherapy. So this is in short about nasopharyngeal carcinoma, and these are the references. Hope you like it. Thank you. Bye. See you in the next video.